So, this lecture is focused on the physical changes as well as the emotional changes that occur in the postpartum patient, and focusing on the nursing care related to that and how we care for those patients, as well as looking at bonding and attachment, and those emotional changes that occur in the mother as well as in the family. So, the best way to remember your focused assessment when it comes to postpartum is BubbleHe. BubbleHe is an acronym that helps you remember the most important pieces of our postpartum patient. It doesn't mean that the rest of them is less important. It just means that it is the things that are most likely to have potentially negative consequences, or even just the most directly affected by being in the postpartum stage. A lot of these systems are things we still check in any patient, like, for example, bowel and bladder. We still check in all of our patients, and we don't assess it any differently in our postpartum patients. It's just that it is a focus because they do have an increased risk of having complications in those areas. Um, so, BubbleHe stands for breast, uterus, bowel, bladder, lochia, episiotomy, home ensign, and emotional status. And we will go through each system individually. So, some of them are not all encompassing, where it talks about what is being assessed. For example, episiotomy, we're not just looking at an episiotomy site. And as discussed before in class, episiotomies aren't even encouraged like they used to be, depending on the provider. So they may not even have an episiotomy, but episiotomy helps us remember to look at the perineum, not even just episiotomies, but also if they have lacerations, if they have hematomas, bruising, swelling, all the other things that can happen in the perineal area. And then home ensign, it is no longer part of evidence-based practice to check a home ensign, where you, as the nurse, actually push on their foot to dorsiflex it and assess for pain in the back of the calf. That pressure, that forceful pressure, can actually dislodge a clot if there were one present. So instead, we tell the patients to dorsiflex their foot to see if they have pain along the back side of that calf. But home ensign, as part of this acronym, helps us remember to check for blood clots. These patients are at a greater risk of blood clots, and in a moment we will talk about why. So BubbleHe is an acronym that helps you remember all the parts. So when we're talking about a patient that is postpartum, generally postpartum encompasses 6 weeks after baby is born. Sometimes they will be followed a little bit longer, like, for example, with cesarean section patients, usually 8 weeks is kind of considered that time period because it takes them a little bit longer just from having major abdominal surgery. But otherwise, most postpartum changes have resolved, and they are past that part of having increased risk of complications related to being postpartum after that 6-week period. So the biggest system affected by being postpartum is, of course, the reproductive system. This is what gives us our babies. So when we're looking at the reproductive system, and when we're looking at the patient's body in general, the uterus is the number one important part of their body, because the uterus is what is most likely going to kill them. Postpartum hemorrhage is the number one cause of mother mortality in the postpartum patient. So making sure that uterus is checked often and make sure it's checked accurately, to assess for any complications, is of prime importance. So when we're talking about uterine involution, involution is the return of the uterus to that pre-pregnancy state. So as it shrinks back down behind the pubic bone, as it contracts, making sure we have a normal involution process versus subinvolution, which we'll talk about in a minute when we talk about complications. That is where it does not return to pre-pregnancy state at the rate it should, or there is something that is causing that uterus not to contract down as well, which can cause postpartum bleeding and hemorrhage. So the normal involution or descent of the uterine fundus is that the fundus is typically found at the umbilicus, right immediately after birth, or maybe a centimeter above. So at or above or below a centimeter is what we're looking at for the umbilicus. It should be in the middle, midline, right at the umbilicus, and it should be firm. It should feel kind of like the firmness of a fist or a grapefruit, and it should not feel boggy. Boggy is the term we use to describe it when it feels kind of squishy and soft. Squishy and soft means that the muscles are not well contracted, which means that they have a high risk of bleeding. So we want it firm, we want it midline, and we want it at about the umbilicus, maybe a centimeter above or below. Then it descends approximately 1 to 2 centimeters every 24 hours until within about 2 to 3 weeks it descends completely behind that pubic bone and is no longer palpable. So it doesn't take very long in the grand scheme of things for that fundus to go back to its pre-pregnancy size. Part of also what is occurring in the uterus is called after pains, which are very normal and very common. After pains is exactly what it sounds like. It's pain occurring after birth. So this is the cramping type feeling that women will feel in their abdomen from their uterus, and we want them to have after pains. Cramping means that the uterus is contracting. We want the uterus to contract because those muscles, if they are not contracting, they are not stopping the bleeding. Placenta is about the size of a dinner plate. So it is a huge wound that is left on the side of that uterus. If you've got that big open area of exposed blood vessels and you don't have muscles that are clamping those off, think of the muscles almost like a tourniquet. When they squeeze, they're clamping off those blood vessels. If you don't have those muscles clamping off those blood vessels because they're not tightening up, you're going to continue to bleed. So after pains means they're contracting, which means those muscles are getting tight, which means you're stopping blood flow. So there are several factors that can increase after pains, one of which is breastfeeding. Especially women, once they've had multiple children, they often get stronger and stronger. So when we breastfeed, breastfeeding releases oxytocin. It's nature's way of helping to control that bleeding. So when that oxytocin is released, it not only helps with letdown of breast milk, but it also causes cramping. So when they start breastfeeding, at the start of each feed, oftentimes they'll complain about increased cramping, and that is normal and that is great. It means that the body is naturally helping to stop that bleeding. Now, after pains are only normal for the first 3 days postpartum. It should not continue after that. If they're continuing to have cramping after 3 days, that can indicate either a uterine infection, or it could indicate potentially that there is some retained placenta left in there that needs to be removed, and that the uterus is trying to contract against that retained tissue and it can't. So breastfeeding increases after pains. The larger the uterus has become, the more after pains they've had. Think of the uterus like a balloon. The bigger you blow up a latex balloon, the more floppy it's going to be when you let all the air out. So it has to work kind of harder to constrict back down. Same thing with the uterus. The bigger that uterus has been blown up, think like, for example, a macrosomic baby, a very large baby, the bigger that balloon is, the more it's going to have to work hard to get back down to the size it needs to be. Same thing if that balloon has been blown up many times. If you take a latex balloon and blow it up over and over again, the walls of it get not as strong, so it has to work harder to get back down, and often will be floppy as well once you've blown it up several times. So the more pregnancies women have had, the more stronger their after pains will be, because that uterus has to work harder to come back down to its pre-pregnancy state. So after pains are normal as long as they don't continue to occur after 3 days. So part of also what we're assessing when we're looking at the reproductive system is the lochia, which is your postpartum vaginal discharge. This starts out as red discharge or bloody discharge, and progresses on to white discharge. So if you look at the picture located on the slide, it gives you an idea of what those sizes look like in comparison to when we're talking about saturated versus moderate versus light versus scant. So heavy or saturated is the only one that is absolutely never normal. Heavy or saturated is never normal. And per ATI, saturated means they have, or heavy means they have saturated a perineal pad in 15 minutes. That is postpartum hemorrhage. So if they completely saturate that pad in 15 minutes, that is considered to be postpartum hemorrhage. So looking out for that as well. So the first type of lochia is lochia rubra, and that is your red lochia. So that typically lasts about 3 days. So about the same time they're having those after pains is how long they're going to have the red discharge. Then it will transcend into the lochia serosa, which is a pinkish color. So as that blood amount starts to decrease and it becomes less concentrated, it becomes a pinkish color. And this typically lasts up until about 10 days postpartum. And then as the blood part of the discharge continues to decrease, then you develop into lochia alba, which is a white discharge. And this typically lasts up to about 2 to 3 weeks of postpartum. An important thing to teach our patients when we're talking about lochia is that it will is making sure patients have an idea of when they should start seeing that decrease, but also making sure that they're aware of symptoms that can indicate a problem. Like, for example, if it starts going backwards, if they have lochia serosa and it becomes red again, that could indicate either an infection or retained placental fragments. So making sure that they understand what those complication and dangerous symptoms may be. Another thing we're assessing, kind of related to the reproductive system, is the perineum in the vagina. The perineum gets a significant amount of trauma, oftentimes related to childbirth. So when we're talking about assessing the perineum, whether it be with an episiotomy or without an episiotomy, even if they have lacerations, this can be applied to any surgical wound. Even your cesarean sections or any kind of surgical wound that you experience in med-surg, a acronym that's called RETA. RETA helps us remember the symptoms that we're looking for related to potentials for wound infections, surgical wound infections. So R stands for redness. We wouldn't want to see redness in a post-op wound or any kind of surgical wound or any kind of inflicted type of wound, like, for example, episiotomy. The first E stands for edema. We wouldn't want to see swelling around a surgical site or a wound because that can indicate inflammation and infection. We also wouldn't want to see ecchymosis or bruising. If you have ecchymosis to a surgical site, that can indicate bleeding underneath. Something was not sutured completely, is pulling apart, and there is bleeding underneath the surface of the skin, so internal bleeding. D is discharge, so or drainage. Either word would work for the D. So discharge or drainage, we don't want to see. They might have a small amount of serous drainage, scant serous drainage. That's commonly seen immediately afterwards, but you wouldn't want to see, for example, purulent drainage. You wouldn't want to see sanguineous drainage or anything like that, because those can indicate complications as well. Now, the A is something you do want to see, and that's approximation. You do want your wound to be approximated, which means it's well fitted together, it's tight, it's not opening up in any way. So if it is approximated, we want to see that. We want it to be well approximated and closed. So as far as nursing care related to the reproductive system, there is a lot of hygiene related care. For example, what we call pericare or perineal care. A big part of pericare is, one, using ice packs. Using ice packs can greatly help with pain as well as decreasing inflammation and swelling to the area and bleeding. So making sure that they are using ice packs. Most hospitals now have the perennial pads that have the ice pack built in, so it's a 2-in-1 combo that they can use together. Sitz baths work great, but you can't use them in the beginning, at least 24 hours post, because If they have an episiotomy or a laceration, that wound needs time to kind of get a covering over it. And if you use sitz baths immediately where you are soaking their bottom in water, it increases that risk of infection. So instead of sitz baths in the beginning, ice packs are best, and sitz baths can be used at least 24 hours afterwards. As far as perennial care, they will get a squirt bottle and be instructed to use warm water in it. They can use cold water if they want. Really, the big thing is it's just plain water, and they will spray their perineum off every time they change their pad. And they should be changing their pad every time they go to their restroom, whether it is for voiding or to have a bowel movement. They should be going to the restroom frequently, ideally every 2 to 3 hours at least. And they should be changing their pad every single time they go, even if it looks like that top picture on the slide where it's just scant. They should change it every single time, and they should be spraying themselves off with just plain water every time that they change their pad. We use plain water because a lot of other additives, anti-infective additives like betadine and hydrogen peroxide, have been shown through studies to degrade good skin tissue. So when used as a regular routine product, it is not shown to be effective and can actually be harmful. So just plain water. We don't want to apply any kind of creams or ointments to the site, especially ointments, because they are petroleum based, and with the composition they will actually hold on to that vaginal discharge, keep it against the skin, which harbors bacteria. So it will actually be more harm than good to make that happen. So it is just recommended warm water, warm for comfort, but it could be warm or cold water, but just plain water. So as far as return of menstruation and ovulation, in a patient who is breastfeeding, it can be very undetermined when that happens. For the most part, textbook wise, the first period returns usually within about 6 weeks after they have stopped breastfeeding. That doesn't mean they're not ovulating, though. People can have no periods when they're breastfeeding and still get pregnant. So making sure that patients are aware that they still need a backup control method if they are not interested in getting pregnant again right away. And if they are breastfeeding, typically their periods do stay away until they stop breastfeeding. In a non-breastfeeding mom, the timing is usually 6 to 8 weeks for after they give birth. And for all moms, once they get their first period, it can be alarming because a lot of times it is very, very heavy compared to what they are used to seeing, and then it will kind of taper off to more of their pre-pregnancy volume. So making sure they're aware in the beginning that it will be much heavier than they are usually used to. The body's basically making up for 9 months or longer of no periods, and it is going to be heavier at first, and then it will taper down over a few months. So as far as the breast assessment and breast health, there's kind of two categories we look at. Either you're a breastfeeding mom or you're a non-breastfeeding mom. Most of it is going to be opposite of each other of how we teach them and care for them. One thing that is similar for both breastfeeding and non-breastfeeding moms is both groups are encouraged to wear a well-fitting bra, especially during the day when they're awake. For non-breastfeeding moms, a well-fitted bra will help not only provide support, but it decreases stimulation. Even just their shirt touching their nipples can be enough stimulation to cause release of oxytocin to where it starts milk production. And in a non-breastfeeding mom, you don't want to start that milk production because then they're going to get engorgement. As far as everything else, non-stimulation is the big focus, making sure that they are turning their back away from the shower, making sure that they don't have any other kind of nipple stimulation. They're avoiding touching their nipples because it can cause milk production. Using cold for them is best. So using cold packs for non-breastfeeding moms. Cabbage leaves as well. Cabbage leaves release an enzyme that decreases milk production. So that that will help. I know cabbage leaves can also be recommended for breastfeeding moms as well, but it should be very limited. So the difference in non-breastfeeding moms versus breastfeeding moms and how you use cabbage leaves, non-breastfeeding moms can use them as much as they want, all the time for to prevent engorgement and increase comfort. But with breastfeeding moms, because of the enzyme released by cabbage leaves that will decrease milk production, they should be very careful about using it too often. They can use it for comfort if they're having engorgement, and they can use it after a feeding, but not before a feeding. But they should be very careful about limiting to just when they need it for comfort. It shouldn't be used on a regular basis, if at all, if they can avoid it. So when we're talking about breastfeeding moms, we're going to do the opposite. Instead of cold, we want to use heat. Heat will help with the milk production and help it flow through the ducts a little bit better. We want stimulation for breastfeeding moms, so they want that nipple stimulation. They are still encouraged to wear a well-fitted bra, just more for comfort. It helps decrease engorgement and provide support. And a lot of breastfeeding moms will even want to wear a bra when they sleep at night as well, just because of the support that it provides. So as far as the cardiovascular system, so we talked about with the cardiac system during pregnancy, the blood volume increases by about 50% during pregnancy, which means women gain about 2 to 3 liters of extra fluid just in their blood volume because of supporting that pregnancy. So that fluid's got to go somewhere once that baby comes out. So after birth, they will have heavy diuresis and diaphoresis, or they'll be peeing a lot and they'll be sweating a lot. And it's completely normal as long as they don't have any other symptoms associated with it, like a fever or burning when they're urinating or things like that. It's completely normal. It's expected. They can dump liters of fluid in one day just because of the heavy diuresis and diaphoresis and dumping of that extra fluid. Typically, it only lasts a few days, 3 or 4 days, but some women will report that they're having symptoms longer than that, and that's still okay, as long as they're not having additional symptoms associated with that. So as far as amount of blood loss they should have in the postpartum patient, typically you're going to see 300 to 500 milliliters of volume lost in a vaginal birth. In a in a cesarean birth, you're going to have about 800 to 1,000 milliliters of fluid. So when you have more than that, when you have more than 300 to 500 in a vaginal birth, or more than 800 to 1,000 in a cesarean birth, that is when we start looking at postpartum hemorrhage. So making sure not only during labor and birth, but also during the postpartum period, we're keeping an idea of how much they've lost. Typically in your cesarean postpartum patients, they do have less bleeding in the postpartum period after they give birth, but their volumes are higher because they do lose more during that period of during labor and birth, because it is a major surgical procedure. So another thing we look at in the postpartum patient is coagulation, their ability to clot their blood. In pregnancy, our body is really good about recognizing that an event is coming up that will cause them to potentially bleed to death, i.e. labor and birth. So your body gets really smart about recognizing that, so they build up clotting factors during pregnancy, which is great because it keeps us from dying in labor and birth. But the bad part is they don't go back down right away. So postpartum patients have a higher risk of blood clots because of that. That's why BubbleHe has an H for home inside, making sure we're paying attention to blood clots, DVTs and PEs, knowing what the symptoms are and knowing how to prevent those, such as making sure that they are ambulating early, ambulating often, not putting anything behind the knees, and preventing those blood clots. As far as blood values, most of them really don't change that much. Hemoglobin and hematocrit may change related to bleeding, but postpartum specifically, they don't really change that much. The one that does drastically change is the white blood cells. The white blood cells can jump up to as much as 30,000, and it's normal. It does not indicate infection. It is part of the inflammatory process of the body, knowing that a major event just happened, and it is accommodating for that. It's just going to the major inflammatory process, even though there's nothing wrong, because the body doesn't know and it gets into that battle mode. So for the first 2 weeks postpartum, women may have white blood cell counts that are as high as 30,000. So if they develop an infection, that white blood cell count becomes inaccurate because you can't tell if it's infection related or if it's just part of that normal inflammatory process. So as far as the urinary system and the GI system, we don't assess these any differently than we do in any other patient. We still listen to their bowel sounds, we still ask them about bowel and bladder habits, and we still assess them in the same manner that we do any other patient. This is part of our focused assessment though, because they do have increased risk of complications in these systems, just being a postpartum patient. One of the biggest things we focus on is bladder distension, because of whether they had spinal anesthesia or just the hormonal changes that occur in their body. Bladder retention is very common in postpartum patients, and there's two things we worry about with with urinary retention. One is that they can get a urinary tract infection just like anybody else, and especially with them having so much vaginal discharge in their perineal area, you want that urethra to be flushed out frequently to keep infection from riding up the urethra. And if they're not having that, it increases their risk of urinary tract infections. It also increases their risk of postpartum hemorrhage. If you look at the picture on the slide, the pink part at the bottom is the bladder. Think of the bladder like a balloon. When you blow up a balloon, if something is sitting on top of that balloon, it's going to push whatever's sitting on top to the side. So when you see things like the fundus is displaced to the side, and it doesn't matter if it's left or right, either side, that is an indicator that it is a bladder problem, as opposed to you just need to massage the fundus. Like I mentioned, diuresis or postpartum polyuria, very common. As long as there's no other symptoms associated with it, it's not concerning at all. And then stress incontinence. Stress incontinence is a big thing that women who have had babies, or even during pregnancy, a lot of times it can start have difficulty with. So anytime there's stress on the bladder, like from laughing or sneezing, coughing, things like that, different types of movements can cause leakage of urine. So teaching them how to do pelvic floor training exercises such as Kegels can help decrease the incidence of that. And then as far as GI system, constipation is a big problem in postpartum patients, whether it be from that they got opioids or just from the changes in hormones. So fiber, fluids, and exercise, that's the biggest thing we can stress, as well as making sure that they're not trying to hold in stool. A lot of times women are very fearful of having that first bowel movement after having a baby, and because of that, they will hold in that first stool, which of course will make the problem worse in the long run. And then the immune system, a lot of the immune system stuff we talked about regarding in pregnancy. So the two big things is your Rh immune globulin with your isoimmunization and Rh incompatibility. If mom is Rh negative, she will get that RhoGAM or that Rh immune globulin at 28 weeks of gestation during pregnancy, and then within 72 hours afterwards, because if there's any cross contamination, that's going to prevent the creation of those antibodies from mom, which will then attack the next pregnancy. And then as far as immunity as well, being mindful of immunization. So if she was found to be not immune to rubella during her pregnancy, of course she could not have gotten that vaccine during her pregnancy because it's a live vaccine, and rubella in and of itself is also a torch infection. So we can give it to her as soon as that baby comes out, and it is breastfeeding friendly. There is not a problem with her getting the rubella vaccine once baby comes out. She just needs to be mindful not to conceive another baby for at least 30 days. So, as far as patients that have had a cesarean section or cesarean birth, everything that we've already talked about still applies to them. They're still going to have all of the physical differences. The biggest thing is they have also had a not major infection, major surgery on top of that. So they have potentially complications related to that. Sometimes people think they want a cesarean birth and they can get an elective cesarean to avoid having a vaginal birth and the pain that goes with that, but don't realize the postpartum recovery of that is much, much more significant. So, on top of all the systemic changes we just talked about, they also have things related to having a major abdominal surgery. So, if you see at the picture on the bottom, that is definitely a wound that does not meet our RITA criteria that we talked about as far as looking well. So it is definitely red. It is definitely not approximated with some discharge edema. They have potentials for wound infections and wound dehiscence. Typically their lochia, their postpartum discharge is going to be less because when they go in and do a cesarean section and they remove the placenta, they'll scrape the inside of the uterus so that it contracts better while they're in there. So their lochia is generally less, but their overall blood loss is greater because they have had surgery. Because it is a major surgery, all those things we learn about in post-operative care applies to these patients. So they may have a Foley for 24 hours. They're still going to need to do the cough and deep breathe, just like we do with postpartum or post-op patients. So all those things apply to these patients as well as increased pain management because they have a major surgical incision. So as far as postpartum self-care, discharge teaching, follow-up appointments are very important, making sure that not only for them but their newborn that they have those follow-up appointments in place and that they plan to attend. They need to make sure everything is going well. A lot of hospitals won't even let you be discharged until you can show that you have at least a newborn appointment, because newborns are usually seen within 24 to 48 hours after discharge. Postpartum women, though, unless they have complications, usually aren't seen until 6 weeks afterwards. As far as hygiene, the perennial care is the biggest part of hygiene, and making sure they're washing their hands with everything. Whether it be perennial care, they should be washing their hands before and after, because if their hands are contaminated and they do perennial care, they have that big open cervix that usually is closed and blocking off the sterile uterine environment, but because it's open, increased risk of uterine infections. They should not be taking any kind of tub baths for the first 6 weeks, whether they had a cesarean section or whether they had a vaginal birth, because of with that cervix being open, water can get up into the uterus and cause problems with infection. So showers or tub baths where they are not immersed in the water is okay. Diet and exercise really is not going to be any different. It's going to be more as tolerated. Diet as far as breastfeeding is a little bit different, which we will talk about with the newborn. Making sure they know danger signs to report, abnormalities in those systems, and what to do about those, what needs to be notified by a provider. So another part of the psychosocial is bonding and attachment. So we want to make sure that bonding and attachment is going okay. And unlike what they teach us in the movies, bonding and attachment is not automatic for every woman or even most women. Depending on the situation of the birth, it could have been a traumatic birth. It could be where they didn't get to hold their baby right away because baby had to go to NICU. It could be a product of rape. They could be in an abusive relationship. They could have minimal support systems. They could be very young, like a teenager. There's so many factors that can contribute to where there may be an impairment with bonding and attachment. It could even be the opioids that mom got during birth makes her a little groggy, so she's not able to participate in that bonding and attachment as well. But our job as nurses is first to recognize any kind of behaviors that may indicate there's an impairment in bonding and attachment, and then promote bonding and attachment. So looking for things things like statements of disappointment, like, oh, I really wish I had had a girl. I didn't want another boy. That can seem benign. It doesn't mean they don't love their child or that they don't want their child. It just, statements of disappointment can be an indicator that there may be some impairments in that attachment. If the mom doesn't seem to be willing to participate in care, the baby's laying in the bassinet and she's listening to baby cry without picking them up. A lot of times new moms will talk to their babies if she doesn't really seem to show any interest in interacting or talking with her baby. Those can be signs that we would be concerned with. So one of the best things we can do as nurses to help with that is to encourage them, show them how to care for their babies, show them some of these behaviors that we see that help with that interaction, like showing how baby is showing interactions, making eye contact, and facial expressions and grasp. The babies have a plantar grasp, well, they'll grasp onto mom's finger, and that can help with some of that attachment. And showing them how to provide care, showing them how to do a bath, showing them how to do a diaper change, and having them reciprocate the behavior. One, because when you have them do the behavior, that's part of your return demonstration that you can document as part of your teaching, but it also pushes them into participating in that care. And sometimes all they need is that little push to get them over the edge, to help them get through that part of establishing a healthy bonding and attachment with that baby.